Good evening. I'm Sonu Jain from The Ohio State University, and I'm pleased to welcome you to the inaugural Global Hand-in-Hand webinar series of the American Association for Hand Surgery. This webinar is with the Colombian Association for Surgery of the Hand, ASOCIMANO. We will be discussing spastic hand. Please let me introduce our moderator, Dr. Ida Fox from Washington University in St. Louis. Ida?
Good evening, everyone. I'm really excited to kick off this inaugural series where we involve an international society, and am excited to involve the Colombian Society for Surgery of the Hand. They complement us and parallel our ideals, which are to include hand therapists, and I'm excited to introduce this great panel. We actually we'll start stateside with Dr. Josh Adkinson at Indiana University in Indianapolis. He is the fellowship director there and an associate professor of surgery, and he will be presenting on the basic pathophysiology of the spastic hand. I know this is a really challenging subject. We really welcome questions. Please feel free to put them in the chat. I also am learning about this field, so I'm excited to learn tonight with you and hope that we have a few minutes for discussion at the end. And then I just wanted to give a shout out again to the Colombian Society for Surgery of the Hand, which was founded in 1966. They work closely with the Colombian Association of Hand Therapists, which was formed in 2004. Please welcome them, and thank you all for joining us tonight. Let's start it off with Dr. Adkinson. Thank you.
Well, thanks, Ida, for the introduction, and Sonu for the introduction prior. So my name is Josh Adkinson. I'm a hand surgeon in Indianapolis, and as Ida mentioned, I'll be discussing the pathophysiology of the spastic hand. So as a brief overview, spasticity is a movement disorder that's characterized by a hyperexcitable stretch reflex, a velocity-dependent increase in muscle tone, an increased resistance to motion, and it is part of the upper motor neuron syndrome. So what do we see clinically? In these patients, what you'll notice in the office is that the faster you stretch them, the greater tone that you elicit. And again, it's really important to highlight that this is the result of a hyperexcitable stretch reflex. So because spasticity is part of the upper motor neuron syndrome, I'll discuss both the positive and the negative features of that. So the positive features of upper motor neuron syndrome include spasticity, dystonic hypertonia, hyperreflexia, spasms, and clonus, which is an abnormal reflex response that involves involuntary and rhythmic muscle contractions. The negative features include paralysis, weakness, loss of dexterity, and muscle fatigue. Really briefly, I'll touch on anatomy. So the upper motor neuron pathways originate in the brainstem and the cerebral cortex, and you can see those in the diagram. They're highlighted in green. And these include the corticospinal and reticulospinal tracts, and the pathology leading to hyperexcitability of the stretch reflex includes these tracts, and all of which leads to influences the excitability of the anterior horn cell. The upper motor neuron pathways, they involve the first order neurons, and these are regulated by glutamate. And glutamate is the main excitatory neurotransmitter. Gamma aminobutyric acid, otherwise known as GABA, is the main inhibitory neurotransmitter. And this is relevant because we have many patients on baclofen, for example, and this medication is a GABA agonist. We'll switch gears and talk about the lower motor neuron pathways. These innervate the skeletal muscle, and the cell bodies are in the anterior horn cells. These are regulated by acetylcholine. You can see these on the figure on the right, where the lower motor neuron pathways are highlighted in blue. By way of contrast, I'll discuss how upper motor neuron lesions and lower motor neuron lesions differ. With regard to the site of the lesion, as I previously noted, the upper motor neuron lesions typically affect the brain and the spinal cord, whereas the lower motor neuron lesions affect anything distal to the anterior horn cell. ranging from the anterior horn cell to the nerve roots to the peripheral nerves all the way to the neuromuscular junction. As far as what you see on exam with regard to muscle weakness, patients with an upper motor neuron lesion can have quadriplegia, hemiplegia, diplegia, or paraplegia, whereas a lower motor neuron lesion causes a myopathy or neuropathy, as one might see after a distal nerve injury. Muscle tone tends to be spastic and rigid in patients with upper motor neuron lesions, but hypotonic or even paralyzed in patients with lower motor neuron lesions. And then tendon reflexes are increased in patients with upper motor neuron lesion and decreased or absent in patients with lower motor neuron lesions. The phases of spasticity begin with paralysis, and then they go through progression through hypertonia and contractures. So we'll start with paralysis. So as you know, this is the inability to voluntarily recruit skeletal muscle. And one of the biggest challenges is that the lack of stretching and therapy leads to both myostatic shortening and eventual muscle fibrosis. And this occurs alongside the loss of functional muscle units. Next, the patient develops hypertonia, which is an increase in tone, or otherwise known as a resistance to passive motion. And this occurs over time. And it's exacerbated by the stiff and foreshortened muscles, what we call intrinsic hypertonia. So this is intrinsic to the muscles. They also develop an increased response to stretch. And in this EMG in the lower portion of the slide, this is recorded from the flexor carpi radialis of a patient with left spastic hemiparesis from a stroke. You can see the activity is not only present during the dynamic phase, but also persists in the static phase. And this illustrates the persistent isometric muscle contraction after the stretch reflex that's elicited in the dynamic phase. And importantly, I really briefly want to note that pain can also increase tone, which thereby increases pain, and this creates a spiraling course. And we see that in patients in the office as well. And then lastly, contractures can occur. This is where we see soft tissue tightness that's secondary to hypertonia. And again, these the joints, related to where these muscles may cross become tight. And this is seen in patients who either don't have adequate access to therapy, or in patients who do have adequate access to therapy, but their spasticity is so significant that they're overpowering either the therapy modalities or their splint utilization. I wanted to make a note of associated reactions. So these are involuntary movements that are secondary to voluntary activation of unaffected muscles. So I hear this commonly by patient caregivers, where when the patient yawns, sneezes, coughs, or walks, they will see activation of the affected limb. So, for example, you may see patients who with cerebral palsy, for example, who while they're walking, you may see their elbow begin to flex and their arm elevate. So what are the common causes of spasticity? So spasticity occurs in approximately 80 to 90% of patients with cerebral palsy, 80% of patients with a spinal cord injury, 40 to 50% of patients with a traumatic brain injury, and 30 to 40% of patients after a stroke. What is cerebral palsy? It's an irreversible static perinatal brain injury, and 75% of these occur in utero. The etiology varies, but it includes prematurity, anoxia, or a CNS or maternal infection. And this is by far the most common motor disability in childhood. Spinal cord injuries are relatively common. We see in the United States 75,000 new cases per year, and many of these patients are affected by spasticity. And interestingly, patients with a spinal cord injury rate upper extremity function over bowel, urinary, and sexual function, even walking. So it's really important to this subset of patients. What about traumatic brain injury and stroke? Most recovery of function in these patient cohorts occurs within the first 6 months, but you may see a slow improvement of function within the first 18 months. And in this patient population, the goal is to intervene before the deformities are severe and fixed, but not so early that you might compromise ongoing recovery or operate unnecessarily. And the management options are relatively similar to patients with cerebral palsy. So the muscle imbalances that we see in spasticity often lead to these characteristic postures. So shoulder adduction and internal rotation, elbow flexion, forearm pronation, wrist flexion, digital flexion, and a thumb and palm deformity. And in general, you can see that it affects the flexors and adductors, although exceptions do occur. So the pathophysiology of spasticity is reasonably well understood and leads to these predictable effects on the muscles and joints with some occasional variation. So now I'll turn this over to my colleagues to discuss non-surgical and surgical management, as well as our therapeutic strategies.
Great, thank you. So next, I have the pleasure of introducing Dr. Carlos Torres, who is the president of the Colombian Association for Hand Surgery. He is a professor of plastic surgery and head of the hand micro and peripheral nerve surgery division at the Hospital of San Jose in Bogota, Colombia. He's also director of the Hand Fellowship program there. Tonight, he'll be talking about non-surgical treatment of the spastic hand, and I'm excited to hear from him.
Thank you, Ida. Thank you, everyone, for being here. It's a great honor for us to share this webinar with the AAHS, or the Colombian Association for Surgery of the Hand. It's great. It's a great success to be here with you. I am going to talk about pharmacological treatment for spasticity. Pharmacological non-invasive treatment for spasticity. I live in Bogota, Colombia, as Ida said. I have no disclosures. As Joshua said, the spasticity have many causes. Stroke, cerebral palsy, neurological disorders, chronic neurological disorders, and the spasticity causes severe disability in physiological function, activity, and provision of care. It presents in wide range of age, children and elderly, middle age, a lot of wide range of age, and present associated symptoms related with the underlying disorder or underlying disease are related. And there is no specific treatment for hand alterations pharmacological. The treatment is systemic. This table is in Spanish, but show the etiologies, as Joshua said. We have to learn about a couple considerations. Three main questions: why to treat, when to treat, and how to treat. There are silly questions maybe, but it's important to know why. Improve the quality of life, hygiene, avoid pain, avoid complications, allow social integration. Independence in daily activities is very, very important, and better provision of care. When the patient presents high degree of paresis, in case of trauma or stroke, if the paresis is worsening in the last 3 months, or in the scale, in the modified Ashworth scale, score higher than 2. And in children, as soon as possible. Later we talk a little bit about this. This is one of the scales, the modified Ashworth scale and the modified Dardieu scale. My colleagues maybe can explain better in the next lecture. How? It's important to know that we are a tiny part of a multidisciplinary team, we as surgeons. And the treatment must be individualized. There is a table that shows our duty as a surgical specialist. But as I said, we are a tiny part of a multidisciplinary team. Pharmacological agents are available in our countries. There are many options, and there are many options, non-surgical options, like you can see in this table. There are centrally acting drugs like baclofen, alpha-dose agonists, anticonvulsivants, and cannabinoids and other agents, and peripheral acting drugs like dantrolene. The baclofen is the first line of treatment. As Joshua said, is working in the B part of the GABA receptor. It's a B gamma aminobutyric acid agonist in the receptor, and it can cause an inhibition of adenyl cyclase, producing relaxation of the muscle. This is the usual dosage, 80 to 150 milligrams per day. And in children, this is the doses. Under 2 years, 10 to 20 milligrams per day, maximum 60 milligrams per day. And in older than 8 years, maximum 80 milligrams. I have to say that baclofen is not FDA approved for treatment of spasticity, especially in children, but is useful and is widely used. The action, the onset of the action is very quick, crosses the blood-brain barrier, but in higher doses. It explains why this drug in low doses it could be not effective, but have those related adverse effects. Presents withdrawal syndrome and must be tapered off when you decide end the therapy. Can produce somnolence, hypotonia, drowsiness, as well hepatic and renal and kidney toxicity, renal toxicity, and in children could affect the brain plasticity in the treatment of CP. This is the usual presentation. And there is an option. I'm not talking about that. About this option is the intrathecal baclofen. The second line of treatment are the alpha agonists, alpha-2 agonists. They're used for clonidine, the treatment for hypertension. This medicine increases the presynaptic inhibition of motor neurons. You can see in this drawing how the tizanidine acts, how the baclofen acts in the synaptic union. This is the usual dosage, 2 milligrams 3 times in the day, maximum 36 milligrams a day. And in children, this is the usual dosage. Is highly effective in tone reduction as well as baclofen, but is better tolerated and could be adjuvant in neuropathic pain. Can produce sedation, serostomy, weakness, hypotension because the chemical composition, but is not well known, and QT prolongation could produce renal toxicity. This is the usual presentation. And the third line of treatment are the benzodiazepines, especially diazepam. It acts in the receptor GABA, especially in the subunit A, reducing excitability. You can see here the usual dosage of this medication. Helps with the sleep in patients, especially children. Is especially useful in seizure and spasms, and have a variety of presentations. Its adverse effects are sedation, weakness, urinary irritation, maybe constipation, and can produce tolerance and dependence, as well as withdrawal syndrome. The conclusion in the literature is, practically speaking, the choice of an agent may be determined by interacting medications, tolerability of side effects, dosage form, availability, and individual response to the therapy. It means all the pharmacological agents can produce effective treatment of spasticity, but you have to choose the better drug for your patient. It's a little bit simplest, but it's the truth. There are other agents like dantrolene, is peripheral acting medication. In Colombia, dantrolene is not available. It's only used for malignant hyperthermia, and it's not available in hospitals. Gabapentin, if the patient have epilepsy or another disorders, and cannabinoids is now in research, but no, it's not recommended for treatment now. As I said, all the pharmacological agents have similar effectiveness, but you have to understand that it's a part of a multimodal and multidisciplinary treatment. And the choice of agents depends on interacting medication, tolerability of side effects, and individual response. Thank you for your attention.
Thank you so much. I think we'll have a lot of questions about some of the different agents, but we'll move along first to discuss Botox, which is also a non-surgical treatment modality. And I'm delighted to introduce Dr. Constanza Moreno, who's also from Bogota, Colombia. She is going to she is chief of hand and microsurgery at the Santa Fe de Bogota University Hospital, and is a clinical professor in the Universidad de los Andes, and we'll be talking about Botox treatment for the spastic hand to continue with sort of the steps of management prior to considering surgery in these talks tonight. Thank you so much.
Thank you, Ida. And it's a pleasure for me to be here, and it's a privilege to talk about something that I used to do some years ago, but I still love it. I have no conflict of interest for this talk. And we start talking about the botulinum toxin. This is a protein produced by Clostridium botulinum. And after some processes that includes a culture, a centrifugation, the acidification of the toxin, the final form is diluted in human serum albumin and frozen dry, sealed, and stored in vials. The Clostridium botulinum produces 7 toxins, and all of them are neuroparalytic agents. They're named from A to G, and the most common, the most used type is the type A. The botulinum toxin blocks the neuromuscular transmission. As you can see here on the right side of the image, there are 2 chains of the toxin, the light and the heavy chain. These chains occupy the receptor and block the neuromuscular transmission. The mechanism is the inhibition of the release of the acetylcholine acetylcholine in the synapses, in the neuromuscular synapses. And the clinical effect is muscle weakness. There is a resumption of synaptic function by synthesis of new receptors and some remodeling of the synaptic area. And this process explains the reversible effect of an injection of botulinum toxin. Generally, the muscle function returns to the baseline in about 3 to 5 months after the injection. In cerebral palsy, the general objective of treatment is to maximize the function and minimize the secondary problems such as joint contraction. Of course, delaying or avoid the need of surgery is important. And specifically in the hand and upper extremity, they have many goals of treatment, that is the preserve the grasp and release function, to maintain the first web space and the ability to transfer objects and the bimanual function of the patient. And also it's important to maintain the independence in the activities of daily living, and be able to use the hands to support the patient during the walk. The main indication is the reduction of spasticity. Is the main goal that we pretend using the botulinum toxin. But it has been indicated as an adjunctive treatment in combination with casting, with physical therapy, with electrical stimulation. And there is summed up as adjuvant in functional gains. The evidence in this paper that I showed you here, this systematic review shows that, or support it supports the use of the toxin as an adjunctive treatment to reduce spasticity, but not specifically to gain function of the patient. When to start with the toxin? Before 2 years old, during the preschool time, the target is to maintain the grip. Of course, the grip is not working because the pronounced pronation, the thumb in the palm, the thumb in the palm limiting the opening of the clamp, and the palmar flexion of the wrist. The treatment targets the pronators, the intrinsic muscles of the thumb, and the wrist flexor specifically. In the school age and the adolescents, the injection can be indicated whenever the progress in re-education and motor acquisition is slowed down. The weight of the child allows the injection of several muscles at the same time because the patient is bigger, and the injections are repeated once or twice a year for several years, depending on the benefits and tolerance of the toxin. If the result is insufficient, maybe we need to think in another therapy, a surgery or something, or something different. The dosage, the maximum dosage depends of the type of toxin we are using. Here you can see in the slide the different commercial presentations and how much you can inject in the patient for time to time. And the recommended dose by Common in 2013 is 2 to 4 units per muscle, of course, keeping the maximum dose per injection time. About the technicals for injection, this one is the most common technique. The muscle to be injected is identified by anatomy, the palpation of the muscular mass, and the movement of the patient is done, and then the needle is inserted. And in this example, you can see how the needle is moving when you put the needle inside. Of course, it has to be done under general anesthesia or under sedation. And the movement of the needle has to be sure that it's on the muscle that we're going to inject. This is just an example taken from YouTube. Sorry. The other techniques are the EMG guided punction. This technique has shown a greater improvement in the results of the patient. The electrical stimulation gives or provides a reliable information about the position of the needle within the muscle. But something I don't like about the electrical stimulation is the dead space between the tip of the needle and the syringe, and how much toxin stays in this hose that is in between these two areas. My preferred technique for injection is the ultrasonography. It's a reliable and reproducible image method with using the muscle anatomy, as you can see here in the right image, the visualization of the muscle can be used as an alternative to electrophysiological techniques, and you can see the muscle with the ultrasound, and you can guide the needle to inject exactly where the muscle mass is. And it's an easy method once you learn how to see the muscular structures. There's no contraindications except the hypersensitivity or the allergy to the excipients of the toxin. A temporary contraindication is infection at the puncture site. And the adverse events were few. They are minor, they are transient, and there were no permanent adverse effects. You can see here the reported adverse effects in the upper extremity. About the outcome evaluation, the most important criteria is the clinical response based on functional goals. However, there are several scales. Each one has a different objective. I will name the scales: the quality of upper extremity skill test, the Canadian occupational performance measure, the pediatric evaluation of disability inventory, the goal of attainment scale, and the Ashworth scale, that is like a rate of the individual muscles and the response to the management. And I think another objective measure is the range of motion, how the range of motion improves, how you can extend the wrist, how you can open the first web space, or how you can reduce the pronation of the patient after the injection. In conclusions, you need to have a very good, very clear goals of treatment. You need to be sure that be aware that the toxin is an adjunctive treatment using with different modalities. There is doubt about the functional gains using just the toxin, and there is evidence that support the use of botulinum toxin to reduce spasticity. That is the main objective of the use of the toxin. And there are several scales for outcome evaluation, even though I think the most important is the range of motion and how is the response regarding the goals of treatment. Thank you very much for your attention.
And thank you. I think that we'll keep moving. We have good momentum, and we're going to get to discuss a little bit about surgery now, as Dr. Sabrina Gallego joins us from Medellin, Colombia. She will be talking to us about what she has done in her practice setting and sort of about the evolution of care throughout the pandemic and back. And I'm very excited to share her talk about not giving up hope and working hard and thinking through things carefully, which I think is really important to this field.
Hello, everybody. My name is, as Ira said, Sabrina Gallego. I'm a plastic surgeon and hand surgeon from Medellin, Colombia. And I'm really honored, as my colleague said, to be part of this webinar dedicated to spastic conditions of the upper arm. I thank to the organizers for their kind invitation. I'm going to be sharing with you more my experience about a mission, humanitarian mission that it's taken every year here in Medellin, Colombia. We call it La Misión de la Esperanza, which is Mission of Hope. And we treat patients with hand differences and lately with spastic conditions in mostly vulnerable patients. So it started a lot of years ago, and as all good studies, it started in a magical place, not quite under the tower, you know, but in Paris when I trained, specifically at the Institut de la Main, or the Hand Institute, that is here near the Seine, and where I trained with my professors there. So besides hand surgery and getting in love with the city, I had to just go all the way to Paris to learn that in my country, they were surgical missions dedicated to treat hand conditions. And one of the people who liderated this was one of my professors, Dr. Philippe Valenti. I imagine you all have known about him. He came to Colombia 1 or 2 times a year since 2000, and they work hand to hand with 2 foundations in Armenia and Ibagué to treat especially congenital hand patients. So it was mostly congenital. They did also sequelas for brachial plexus palsy. But and there were another surgeons that were training in Paris like me, but before me, they have participated and maintained the patients and care for the patients after they leave, and it was a really good model to follow. So the first mission dedicated with patients for spastic conditions was in 2009, when they invited one of my other professors, Dr. Caroline Leclerc, to participate there in Armenia and Ibagué. I was already back home, and I went there with her and get involved in the treatment of these patients, and you know, doing what you love and could help people is really important. So it was a really good experience, and I enjoyed very much. I have a lot of good friends from these missions, because they were going from Bogota also, and Ibagué, Armenia, people from France, Dr. Philippe Valenti. This is another professor of us, Rui Ferreira from Brazil. And, you know, we try to share all the objectives that we want to get in a surgical mission, that is to treat patients that we believe were abandoned by the system. We don't have a really good bad system is not a bad system, but you know, sometimes in people like ours, it's difficult to get somewhere and to treat all patients affected by these conditions. The second objective of every mission is to help patients that doesn't have this easy access to health services. And one of the most important things I believe missions are for is to teach classic and emerging techniques to young surgeons. In that way, they can applicate and teach further these new or old treatments where in sites or in sites you don't have a lot of reach for the patients. So around 2011, Dr. Oscar Arias, who you see here in the left, became a part of a huge organization in Medellin that was called, or it is called, Promotora Médica Las Américas in Medellin. And this organization has rules and ONG called La Fundación Las Américas, and they together started the first mission in Medellin, Colombia, with the help of the La Chaîne de l'Espoir from France. I immediately got involved in the missions that I captured since then. So you can see here one of my professors, Dr. Valenti, and Dr. Caroline Leclerc, Rui Ferreira, he's Jean Cani from Marseille, and all those are voluntaries for the mission and residents in that time, plastic surgery residents. So at the beginning of the missions, we tried to pre-evaluate the patients for past medical histories and basic images and basic physical examination. And we brought the patients to Dr. Caroline Leclerc consultation for she to evaluate them and indicate surgeries. But progressively we learned that we can do better exams, we can repeat exams and know better the patients, do video assessment, repeated observations, functional assessments, injection of botulinum toxin also. And in that way, we can pre-select patients better, like 2 months before the mission. When the mission is ruling, we do like a staff. We have patients, we have occupational therapists, residents, we have physical therapists, and we have the surgeons that are going to operate on the patients. The residents and also help with translation, paperwork, and everything. I'm going to show you a little bit of how many patients we have treated. For all the cases we have treated in the mission is around 400 children operated. And this is the spastic patients we have treated, mostly major patients. This is over 16 years old, because we as you can imagine, we have to have the collaboration of the patients with for these surgeries. We also treat patients with congenital hand anomalies, as I told you before, traumatic sequelas of hand trauma, and obstetric brachial plexus. The spastic patients in total are 132 patients with a median of 14 years and a range between 4 and 58 years. They were mostly men. The principal cause of their spasticity was cerebral palsy. And we made a median of 2 surgeries by patient and 2 procedures by surgery, between 1 and 5, including tendon transfers, hyperselective nevrotizations, arthrodesis, mostly that. You have to imagine that in a surgical mission is different to treat patients than when you do it and you can follow the patients all the year long. And when you have the patients here, they came to your consultation, and it's different that patients that are coming from countryside and everything, and we have no opportunity to see them regularly sometimes. We believe education is an important part of the mission. These are the residents that were invited to participate this year. They were beneficiated with the learning experience first and active participation in all cases. That is important. We think it's really important because we know that education will bring us advance. They assist in surgery and they had the opportunity to learn from the masters. You know, Caroline Leclerc, Dr. Caroline Leclerc, Dr. Rui Ferreira, they are all innovative surgeons in this important field. The other thing is they can go to replicate and to apply what they learn. And we also invite some surgeons from the country and the city to see what we do and to teach them how to treat these patients. It was before the pandemic. The pandemics that in 2019 we were able to evaluate in the mission after a pre-selection 22 spastic patients, and we operated 19 of these evaluated patients. 3 patients were operated from both the upper and lower limb, and after 2 months, all the patients were rehabilitated and with no important complications. And in other missions, we see the same thing. These are surgeries that can be done in an ambulatory basis. They don't have to stay in the hospital. And we believe it's important when we have to have bigger operations, we don't do it during the missions. During that time, you know, this field of neuroorthopedics and especially surgical treatment, functional treatments of spastic patients have evolved. There have been papers written, some of them for Dr. Caroline Leclerc, so I'm proud of show that. And we, as the mission and with the help of Caroline Leclerc, are doing, and with also with the association of hand Colombian surgery, we have done some webinars, and we have participated in the meetings, annual meetings of the association also. We were invited to participate in all the symposiums that Caroline and the other experts in the world of field have been doing in Paris. The last one was here in Amsterdam. The first one was in Paris. And we have the opportunity to share with non-surgeons around the world. So then 2020 was coming to make a better mission to treat more patients, but COVID arrived. And that was a big problem for us because we have to practically start all over again. To restart was really difficult. Our supporting organization was run out of funding during these years. The recruitment of patients was really difficult. We've been recruiting patients for 2 years. And during the COVID time, 2020 to 2022, the clinic was focused on treating patients with COVID, so we couldn't afford to make surgical nations, so we stopped. And the mission we did this year, we only could recruit for operation 9 patients. So we saw a little bit more, but they were not all quite prepared for surgery. We also indicate treatment with botulinum toxin and therapy, and we have now the opportunity to bring people like hand therapists or medical doctors who help us with medical problems in the mission. So that's an important thing we improve for these patients. So what we do know after all this time, we have to write down the patient's family and the patient and family expectations. We have to keep functional records of all patients evaluated before and after surgery, and not just only evaluate movement, but the functional improvement, and compare it with the expectations of the patient and their families. We are trying to fill these forms actually, and in the other side we put the surgical plan and the expectations. So we have to, or we are trying to get with the patients. The most important thing I can let you know is keep record of everything. We don't have a lot of statistic in these patients because we didn't do it the first missions, but we're improving. So I hope we can show our results after. What we don't know yet is, has the treatment of spastic patients improved in Colombia? I don't know. I see a lot of people trying to do good things, as you saw with my colleagues in Bogota, but there are a lot of cities in Colombia that don't have the opportunity to have the professionals dedicated to the care of these patients. The physician and patients are aware there are surgical treatments that are emerging and evolving to improve them. Yes, I want to believe they know. I want to believe we are sharing more, like in the webinars we were doing and the meetings. And I hope this thing didn't stop after COVID. Are there more hand surgeons now in Colombia dedicated to treat those patients? I don't know. There's a question I am not able to respond. Probably my colleagues will help us after. What we have learned through the years, it takes a really committed local team to put together a good surgical mission that could help a lot of patients. You know, find patients who need help is the easy part. But not sometimes sometimes we cannot help all patients. Sometimes surgery is not the solution for patients, but sometimes it is. Even if we cannot show off from an excellent result. Sometimes, as my previous colleague said, is the matter of improve a hygiene or taking care of the patient's being for her families or for their families easier, you know. Follow-up is not always possible when you do missions, but you must try hard to do it because it's the only way you can get good results and help patients. And operation, as I told you before, operating patients in surgical missions is quite different to treat them from in the regular practice. Another good thing I've learned all those years is that you have to have fun and you have to keep in contact with your colleagues and with your mates. Thank you very much for this opportunity, and I'm open to questions.
Thank you so much. I think we all have a lot of shared feelings about sometimes feeling like it's really hard work and we're just getting things back again. Before we go into questions, I want to give Stephanie Kannas a chance to share additional therapeutic management of the spastic hand. I'm delighted to introduce her. She is an OT by training with a added certificate of hand therapy. She is currently assistant professor of physical med and rehabilitation through the College of Medicine at the Mayo Clinic in Rochester, New York, and is similar to all of the other contributors tonight, a teacher, clinical lead hand therapist, and teaches the occupational hand therapy fellowship there. Please go ahead, Stephanie. Thank you.
Thank you, Ida. It's my privilege to talk tonight on non-surgical management for these patients. And so I'd just like to also state that I have no disclosures. This is a case study I'm going to talk about tonight. They have a typical sort of presentation of spasticity, but I've known this gentleman for a long, long time. And I'd like to just reiterate that therapy is a multimodal approach. So it's just not one thing. We can do a variety of things. But probably one of the things therapy is known best for is what type of splint or orthotic will help that hand the best, and why do we want to do that? So when we look at all the different non-surgical rehabilitation approaches, there's a lot of different things we can do. And at my facility, I have the luxury of working with occupational therapists that specialize treating patients with upper motor neuron syndrome, so the two of us can work as a team to get the patient the best treatment. But what we often specialize in is doing orthotics. We might have the patient go on a home stretching program. Electrical stimulation is one of the modalities that we can use. And then an emerging practice for us is dry needling. We really want to do these things because if we can we increase any function with that patient? Can we decrease caregiver burden? But more importantly, we want to prevent any skin breakdown because we'd hate to get an open wound, especially like in a palm of a hand or at the antecubital fossa. And so moving into orthotics, why do we want to do orthotics? And they do have moderate evidence to support that this can be helpful working with patients who have spasticity. And we really are working at, initially the patient can have some primary spasticity that can lead into muscular fibrosis or contraction, and then they can get that intrinsic joint contracture. And so can we use the splints to prevent that intrinsic joint contracture is one of those things. And most importantly, we want to lead to that skin breakdown. As you can see in this distal palmar crease, that patient has some skin breakdown. For some of the patients, their hands might not smell very good. And from a social standpoint, it's really important that they keep their hands clean. So unfortunately, in this population, we really have to look at each patient individually, and we have to tailor what we're going to do from a splint design for that patient. So this is a patient that I know dearly from our hand clinic, and we really need to look at their presentation. Are their caregivers going to be able to put a splint on them? Because I can make it, but if they can't get it on at home, it's not going to do them any well. And so it really takes a lot of clinical reasoning from my standpoint. Moving forward with all of this is there's lots of different types of splints out there. You could do something just very simple. You could buy this out of a catalog where you do a palm protector. Some patients, their hands are so tight that you could use this carrot splint. That is the blue carrot in the picture on the left. Or sometimes we can go ahead and we can make a static resting splint. From there, some patients might benefit from a static progressive splint, where what you're doing is you are creating some stress on the muscle tendon unit, and you're serially cranking the splint as they can tolerate the new increased length. And there are then other manufacturers out there that make dynamic splints because they're worried about if the patient has increased tone while wearing this splint, they would hate for them to get any type of a hand injury or skin breakdown. And so while they have increased tone, the splint's going to give. And then when they relax, the splint will gain the stretch again. And so moving forward, one of the contradictions to splints is if you see someone with severe spasticity, you might not want to splint them because it can lead to rebound spasticity. And then again, we could lead to skin breakdown. So moving into my case study, this is a gentleman that I know dearly. He's had some spasticity for a prolonged period of time. Ironically, he went to a local hand therapist, never really liked that splint. It stayed in the bedside table, wouldn't wear it. But yet would complain to me that his hand wouldn't work and he couldn't open it. So I finally caved in, brought some splint material to him, and I went ahead and made him a splint. You can see in the pictures, I really tried to preserve that first web space. I tried to get those MCPs as high as I can, but it really looks like I made an intrinsic plus splint. With these patients, it's really important to gradually increase the wear of the splint because I would hate to cause any skin breakdown. And then if you're the only therapist, use a high stretch bandage or an ACE wrap to help you form that splint so you have multiple hands. So in research, they talk about using stretching devices, and there's moderate evidence to support these things. When I did a literature search for this, there's 2 studies out of Korea that had patients use these 2 stretching devices 2 to 3 times per day for 4 weeks. They found that the modified Ashworth scale had improved scores, but the scores didn't stay improved if they stopped using the device. So what I got out of that study is this would be an indefinite therapy aid that they would need to use indefinitely. Here at our facility, it's important to teach those caregivers how to do a stretching program. You want to do nice, slow, progressive stretching with prolonged holds. Sometimes this is really nice to promote and keep good skin integrity. And then I always like to use these with orthotics if there's no rebound spasticity. Another modality out there is use of electrical stimulation. So in a study with children with cerebral palsy, they were placed into 3 groups. One who just got the electrical stimulation, one that got electrical stimulation with dynamic bracing, and then another group that got dynamic bracing alone. They found that the children that underwent the combined approach with the electrical stimulation and the bracing had the best function. However, again, you got to continue to do this because once you stop the intervention, the effects diminish quickly. So there's an emerging practice out there. When I was researching this study, I found that can be one of the helpful areas. So it's an emerging practice here in the United States. Not all therapists can do this. It depends on what their state guidelines show. The studies out there show that you can do this with modified Ashworth scales from 1 to 3. And your goal is to put the needle in the muscle that is showing the increased spasticity. So here's my patient. I have my needles. They're down here closer to the elbow. And my goal was to try and hit the FDS. So before I started, you can see there's some nice tightness in the FDS. I inserted 2 needles into the flexor wad, but I didn't hit the FDS right away. I hit a 3rd one in there. Almost within 30 seconds, his hand started opening immediately. And I wanted to get twitch responses. And so I kept sort of pistoning the needle in that FDS to get my twitch responses. And then the hand kept opening up further and further and further. And so with this, we combined it with that splint that I had made this gentleman earlier. And the 2 of us were amazed at how long these results have lasted so far. So with splinting in 1 session of dry needling, this is a result that's lasted him for 3 weeks. And so this was my phone call with him the other night just to see how he was doing, and he was really happy. So in conclusion, therapy is a multimodal approach, and we need to maximize what's right for each patient. And so really our goals are to increase range of motion, prevent skin breakdown, decrease caregiver assistance, and possibly increase patient independence. So thank you for your time tonight, and I really appreciate being able to be a speaker.
Thank you. I think we'll open the floor to questions. I will start off the first one to you, Stephanie. It's about the SABO splints, I think.
Yeah. Let's see. I haven't personally had a lot of use with SABO splints, but I know a lot of people have had good results with them. And that's their splints out there on the market are the ones that allow for increased tone to prevent additional skin breakdown. I know sometimes they can be cost prohibitive for certain patients. So if they can't afford them, we need to look at other alternatives.
Great. And then I think earlier we had some questions about sort of first line medications. I don't know if anybody else has suggestions. All of the meds have side effects, obviously, especially in the older patients. It sounds like Colombia is ahead of the US in multidisciplinary care. I think people might be surprised at how fragmented the care sometimes can be here. So we as hand surgeons are often the first people to make suggestions about medications. And thank you, Dr. Torres, for suggesting low doses of baclofen as a starting point. Tizanidine is an option as well. And I agree, starting at bedtime, they often cause some hypotension. So definitely something to keep an eye on. They can also cause some confusion and drowsiness. Anybody else with input on first-line medications for hand surgeons? I think there's another question about intrathecal baclofen. I've definitely seen it in patients with spinal cord. I haven't seen it in other populations. Anybody else want to comment on intrathecal baclofen?
Sincerely, we don't know. In Colombia, it's not used. I saw in the literature, but in Colombia, or at least in my hospital, it's not used.
No, exactly.
We have some patients in Indianapolis who have intrathecal baclofen pumps, and that's usually managed by PM&R here, which we're fortunate to have. So I don't play a role in that. They work really closely with the patients and sort of manage that service directly with neurosurgery who implants the pumps. So we don't really play a role in that here. And fortunately, our PM&R docs are really good about doing the medical part, and we get involved in the multidisciplinary clinics only for our surgical input generally.
And then a question about the role of SDR. Is that dorsal rhizotomy? I have not done that. I'm not a neurosurgeon. Any neurosurgeons on the call, or go ahead? So I don't have much experience. I know I've tried to refer patients for this, especially for pain associated with brachial plexus injury, and I have unfortunately had a lot of pushback if they're incomplete. So it's only in our center for people who are complete brachial plexus. Does anybody else have any comments? Otherwise, we'll switch gears and talk about dry needling. Question about that and treatment for dry needling. I'll let you read that. I don't know all the abbreviations there.
Sure. So in dry needling, I have literally done one patient one time for spasticity, and I went based on 2 articles that I have read in out there in the literature, and they are, one was the effectiveness of dry needling for upper extremity spasticity, quality of life, and that was in acupuncture medicine in 2021. And it was, you were going into any muscle that had a modified Ashworth scale of 1 to 3. And the goal was to continue to piston and actually try and get a muscle twitch. In the literature, it said at most they would do it once a week. And they would leave the needles in for a certain period of time. But again, I've only done it with one patient. I noticed immediate results. And I think it just, from what I've been taught in my training, it just helps give a brief neurological reset.
I'm not sure about the dry needling. I have no experience on that, but since you are puncture the patient, why you cannot put some botulinum toxin or something over there? So if you're puncture the patient, I don't know if just the needle is enough, or maybe if you put something else, maybe will work better.
Yeah, because our needles are just, they're solid monofilament, tiny, tiny little needle. But it was just, after reading it, I was like, oh, I might try it. And I have my dad, who is a really good guinea pig, to let me try things on him.
That is a great story to end on. So I will turn it over to Sonu, who will close things out. Wish we all had dads like that. Thank you.
Awesome. Wow. What a great webinar. Well, thank you, Ida, and to all of our wonderful speakers for an exceptional and informative webinar and a real tough subject, to be honest. Special thanks to the Colombian Association for Surgery of the Hand, ASOCIMANO, for the collaboration on this webinar. They're the guest nation for upcoming AAHS meeting in January. I'd like to thank you, the audience, for spending your evening with us. I invite you to join us next month for our combined hand-in-hand webinar series with the American Society of Peripheral Nerve, where we'll be discussing the topic, "My nerve surgery failed. Now what?" Good night.
Good night. Thank you.
Thank you so much. Good night.
Thanks. Take care. Good night,
Good
everybody.
night, everybody. Thank you.
Good night.